Our next speaker is Dr. Stephen Kopecky. Dr. Kopecky is professor at the Mayo Clinic in Cardiovascular and Internal Medicine. Dr. Kopecky focused on cardiovascular disease prevention, where he sees patients at the Mayo Clinic Cardiovascular Health Clinic. He has written numerous articles for peer-reviewed journals and has received multiple Teacher of the Year awards from Mayo's Division of Cardiovascular Diseases and the Department of Internal Medicine. His research interests include the role that lifestyle, including diet, exercise, and proper nutrition play in risk prediction and the development of cardiovascular disease and statin intolerance, especially as it affects patients with familial hypercholesterolemia. He is the author of the book, Living Younger Longer. Live Younger Longer, 6 Steps to Prevent Heart Disease, Cancer, Alzheimer's, Diabetes, and More, which is published by Mayo Lay Press in 2021. He's the contributing editor to the Mayo Clinic's Healthy Heart for Life book. Dr. Kopecky is the past president of the American Society for Preventive Cardiology and is the 2013 recipient of the Jan Kellerman Memorial Award given by the International Academy of Cardiology for distinguished work in the field of cardiovascular medicine. Welcome again, Dr. Kopecky.
Thank you, Mo.
Thanks for coming.
Thank you. Excuse me. Thank you, Dr. Khan. It really is always so great to be here in Reading, such a beautiful part of the world. We'll talk about some prevention issues, and specifically, my wife and I were at a sandwich shop the other day, and this was it was such a nice little sign they had in their window. I took a picture of it. It said, "The whole world is short-staffed. Please be kind to those that showed up." So all I ask is, please be kind to me today. I showed up. I think every one of us knows how that is. Here are my conflicts that we really will not be, I'll stick with guideline-driven things for the medical therapy, the book that Dr. Khan graciously mentioned. And what we'll talk about is to appreciate the role of diet in development of cardiovascular disease. Maybe looking at some things you haven't looked at before or didn't know about before. Because remember, all the drugs that the FDA approves for lipid-lowering therapy are in addition to healthy diet. And then review the last August 2022 cholesterol guideline updates. That may be very helpful for some of you that treat patients with high cholesterol or have high cholesterol or have family members with high cholesterol that like to ask you questions. And then finally, understand the appropriate combination therapy and lipid management. So what can we prevent and how do we prevent it? How do we reduce cardiovascular deaths? And this is just to think to yourself, but is it more through primary or secondary prevention? Meaning primary prevention, that we prevent the actual disease from occurring, or is it secondary prevention, where we wait for the disease to occur and then we treat the disease? You think it's A, that the majority of deaths reduce, or through secondary prevention, A and B, or maybe C, where it's 50-50, or D, that it may be actually more by preventing the disease rather than waiting for the disease to occur. And it's very interesting. In actuality, 80% of the deaths we're going to prevent are by preventing the disease. If we wait for the disease to occur, guess what? Things are going to happen. As the Dr. Khans will tell you, a third of their patients that have heart attacks don't even make it to the hospital because they are at home and die at home. So it's very important that we understand that we need to prevent the disease and need to help our patients to prevent disease. So if you look at the deaths related to the 17 leading risk factors, here is a list, the top 17. Some are lifestyle issues, some are environment issues. And if you divide them up, you can see that for some reason this doesn't layer. It won't layer out, but as you can't see, but the majority of the top 10, 8 of the top 10 daily lifestyle. Diet is number 1. Tobacco, blood pressure, body mass index, inactivity. You'll hear a great talk from Dr. Levy in a moment. Blood sugar, and then there's ambient pollution and drug use. These things are really our lifestyle, but diet is number 1. And if you look at the 6 causes of the disease, the chronic diseases we have that are so rampant, this is the 10-year anniversary of the number 1 cause of early death and disease in this country and now in the world. So really what we put in our mouth is extremely important. In U.S., poor diet is the leading cause of premature death. Death is inevitable, but premature death is not. And we need to remember that. And 84% of the deaths that are premature are cardiovascular. The remainder are cancer, diabetes, and other things. So we're really talking about heart disease. And there is a cost to our food. And of interest, on the left-hand side here, you can see that the national expenditure on food is about $1 trillion a year. But if you look at this Rockefeller report from 2 years ago, the actual true cost of food is $3.2 trillion a year. And that's because $1 trillion of it, the cost is from health, human health, obesity and non-communicable diseases, which is cardiovascular disease, hypertension, diabetes, cancer. So the health cost from food eaten in this country is estimated at $1 trillion a year just from the health costs. Now let's look at our health. Let's look at how we eat. And this is a global and U.S. healthy diet scores by age. Now with smartphones, and you heard earlier that everybody has a smartphone, they can track meals all across the world, in almost every country in the world. And you can see that globally is on the top and U.S. is on the bottom. The global is, in the U.S. is actually healthy, quite healthy here. Oops. Can't walk and point at the same time, sorry. And you can see that within the first decade of life, the U.S. diet plummets to become the least healthy in the world. Why is that? We have the best food delivery system in the world. We truly do. Then it doesn't catch up to the rest of the world until we reach our 5th decade of life, which is kind of sad. And then our diet does get better towards the end of life, and it's not really clear why. Does the diet improve, or do the unhealthy people that have an unhealthy diet just die? That's what happens with cholesterol. A man's cholesterol is higher than a woman until they're in the 70s nationally, and then a woman's cholesterol becomes higher, not because the woman cholesterol is bad, it's because the men with bad cholesterol die. So this is part of the reason. In the first couple of years of life, and we have our first grandchild, 11 months old, and this kid is eating the healthiest diet you've ever seen. Majority of mother's milk. He may get some mango or some fruit, some things like that. But in a couple of years, he will go to a friend's house, and he will get some honey nut something. And if you look at the most popular cereals based on revenue and boxes sold, they're right here, and we all know what they are. There are 2.7 billion boxes of cereal sold every year in the United States. So that's 8 boxes for every man, woman, and child. And a lot of us aren't eating them, so we know who is eating them. And our kids are. About half of the calories we eat every day are habit. And what we're teaching our kids is a habit. And that is open a box of cereal. Very easy. And these cereals are ultra-processed foods. They're called open and eat, heat and eat. They're added calories. They have fat, protein, carbs in them. They have chemicals, salt, plus other chemicals to preserve them. And ultra-processed foods have been defined only about 10 years ago by the NOVA classification, which came out of South America, industrially formulated containing little, if any, intact food. They've also been called acellular. You just don't see much cells in these foods. They're high in added sugar, sodium, and saturated fats. They're low in protein, fiber, and micronutrients. But we eat a lot of them every day. And if you look now at this is pre-COVID, 2018, the total calories from ultra-processed foods in the United States. You can see by quartile, the lowest quartile is on the left, so the least amount is at least 25%. And look at the highest, these are quintiles, sorry. Look at the highest, it's 85% of the calories. And you can notice on the bottom, the younger you are, the more likely you are to be eating high amounts of ultra-processed foods. And the average is about 56% of our daily total calories. And if you look at the effect of ultra-processed food in the diet and the risks of cardiovascular disease, heart disease, coronary cerebrovascular disease, you can see on the x-axis, that's the proportion of ultra-processed food in our diet. The y-axis is the hazard ratio for cardiovascular disease. And for every 1% increase in ultra-processed food intake in calories, there is a greater than 1% increase in cardiovascular disease. So these little things we do every day, this bite here, this candy bar there, our son is an organic guy, and he's a resident now at Mayo, and he eats. He says, "Gosh, Dad, I'm so busy. I have to get these bars, but they're healthy bars." And I said, "Let me see these bars." And so I looked at them. I said, these things are basically organic, ultra-processed food. It may be organic cranberry syrup, but it's still high fructose corn syrup, And if you look at the ultra-processed food intake a different way, this shows, again, ultra-processed food. This is by servings and cardiovascular mortality. You can see on the x-axis is the servings from 1 up to 10 servings a day. And the y-axis is, again, the hazard ratio now for cardiovascular death. And you can see that as you go up to about 7, 8, 9, 10 servings a day, the increased risk for cardiovascular disease is, again, 60, 70%. But the amazing thing is, if you look at this dotted line, this dashed line rather, this is the average intake of ultra-processed food servings in America for every man, woman, and child, 7.7 servings per day. So we ought to eat maybe a couple of servings, and I probably passed that at breakfast. We ought to stick to that. And the saddest thing to me is that ultra-processed foods now have been deemed the #1 cause of dementia in the country. Again, a lot of these chemicals we just don't need to have. I love this study from Spain, percentage of each food group contributing to ultra-processed foods consumed. French fries is their own food group. So what I actually suggest patients do, I started using this a year or so ago. It's the Yucca app. Anybody know about Yucca app? Good. We heard some great talks earlier about digital health. And what we ideally need is a smartphone that'll take a picture of our food as we put it on the plate, and it will tell us what to eat or what not to eat. The smartphones can't do that because it doesn't know if that whipped cream is real whipped cream or if it's just made out of Cool Whip or it's something different, yogurt, whatever. But the Yucca app it came out in 2018, it has about 30 million subscribers. The Yucca, it scans the barcode and rates the food 60% from a Nutri-Score, which is a French public health agency that tells you what's in it. It also looks at additives, which are really important, and it's 10% of the score is based on organic. So it's very helpful, and it will tell you what you're eating, is it something that's good or not. And it's a score of 0 to 100, and if it's a high score, great, that's good. It'll give you colors. And if it's a low score, you can punch a button as to why it's low, and it'll tell you. And it'll work for creams, too, which I think are very important because we're all putting creams on all the time. And as we all know, creams, some of the substances in creams are absorbed in our body. So this is very helpful, and I tell patients it's a point of care. You can look at it in the store and pick the thing up, take a picture, put it down when it says it's bad. And it can help you because we need something that helps patients before they put food in their mouth. And you can eat healthy or unhealthy of just about every diet you want to consider. Mediterranean, vegan, keto, paleo, time-restricted eating, but you cannot eat a healthy ultra-processed diet. And our kids are doing it every day. Now, what does America eat that we shouldn't eat? This is, again, a global study from Lancet a couple years ago, and it looks at the optimal intake. Here is this dotted line, And the high-income North America is this middle part that I've put in red. And you can see that red meat, we're one of the biggest consuming red meat countries in the world. Processed meats, we are by far and away, no one else is even close to us in processed meats. And then the third is sugar-sweetened beverages, or SSBs. We're the highest of that also. But other areas like Central Latin America is coming up close on us. So we got to get back, we got to be number one, right? So these are three things that we're eating that we really shouldn't be eating that much of. What are things that we eat that we don't eat that we should eat? Well, again, same format. Fruits and vegetables, we're doing pretty good on them. We're in the middle of the pack. We're way low on legumes, one of the lowest, and we're way low on whole grains daily. We're pretty good on nuts. But the legumes and whole grains we need to eat more of. I had a patient, a very well-known guy, call me the other day and said, I need to speak with you. I said, okay, we can Zoom. I said, what do you want? How can I help you? He said, I want you to help me sue the American Heart Association. I said, what for? He says, I'm obese and it's their fault. I said, suing the American Heart's like suing the mafia. I don't know if you want to go there, And he said, well, I'm eating whole grains and I'm obese. And I said, well, why is that their fault? They said I could eat whole grains. I said, well, tell me what you eat, breakfast, lunch, and dinner. We went through his average day. He is eating 20 servings of whole grains daily. I said, no one, show me where the American Heart says you can have 20 servings of whole grains a day. You should have a couple, but not 20. Anyway, he hasn't asked me to talk to him again. The other thing is beverages. A million years ago, how many beverages did we drink that had calories in them? Didn't happen unless you were crazy enough to go raid a beehive or something like that and mix it with water. If you look at, this just came out earlier this week or last week, all-cause mortality by beverage. And I like the way this, because it's simple, I can understand this. And I've synopsized the data here. You can see the beverages on the left, the hazard ratio for cardiovascular, this is total mortality now, and then the hazard ratios on the right. So you really see there are three groups. One group, the green, actually you have a decrease in total mortality with what I call the herbals, coffee and tea. Herbals are good. Water is good. Low-fat milk is okay, but don't think you can have 20 servings of it a day. The next thing are artificially sweetened beverages, ASBs, and fruit juice. It's kind of neutral, but maybe have a serving, but don't go crazy with them. And then the sugar-sweetened beverages and the full-fat milk, it clearly seems to have an increase event rate for total mortality. And this is tough where I work and live because we have a lot of dairy farmers in Minnesota and Wisconsin. And it's tough to get them to comply, but I tell them it's one swallow at a time, one bite at a time, one glass at a time. Just try to cut back. This is CV mortality by beverage, very similar, as you can see. So it's not just total mortality, but also cardiovascular mortality. Try to cut back and stick with coffee, tea, water, and then low-fat milk if you want some dairy. So this is the three groups I put it in. Now, what about ASBs, artificially sweetened beverages? Does anybody in this room not use artificial sweetener? 1, 2, 3, 4. Wow, pretty good. I'm proud of you guys. The artificially sweetened beverages, there's a couple of issues about them. And one is that they affect your taste buds. So when you do eat something sweet, you want more of it because you kind of get your taste buds numbed. The second thing is, sugar is metabolized by our microbiome. And a lot of these ASBs are metabolized by our microbiome. And we have to be very nice to our microbiome since there are more of them than there are of us in our body, as you probably know. So what's interesting is that the FDA has this term in the USDA of GRAS, generally recognized as safe. And they've said that these things like erythritol are generally recognized as safe. And I'm a fan of monk fruit because it so far is safe, but they've been starting to put erythritol in with monk fruit. And you can buy these at Whole Foods or at obviously Costco's or Sam's Club, all these box stores, and they're very helpful. But if you look at a recent study that just came out about erythritol, it's not metabolized by the microbiome, but it does have an impact on platelet function on the left. You can see the red is the erythritol. The platelet function, actually adhesion rates go up significantly. The vehicle they put it in went up a little bit, and then no things without any collagen didn't change at all. And on the right is actually the in vivo thrombosis in an animal model. And the time it takes to clot, you can see it actually shortens the clotting time when you have erythritol. So you say, oh, come on, this is just something in a test tube. Tell me something that it's worthwhile. Well, how about major adverse cardiovascular events? Cardiovascular mortality, fatal, non-fatal stroke, and MI. On the left, you can see here is the quartile, with the red quartile being the highest group of people eating erythritol. At 3 years, you can see there's a significant increase in major adverse cardiovascular events in the fourth versus the first quartile. In the US, the increase was about 1.8, the hazard ratio, and in Europe, about 2.2, so it was a multinational study. So I think this is one more thing we need to keep off of our plate, at least for now. And so stick with water and the herbals, and try not to put too much sweetener in it. Now, this was the view from the very beautiful dinner we had last night, looking out at Mount Bali and Mount Lin out to the west. You can see the Sacramento River here in the bottom. What a beautiful area that many of you get to live in. This is just great. My view from my house on the Mississippi River looks similar to this, but the river is about 10 feet higher than it normally is. And our daughter is there now monitoring it and said, we're safe. We're still about 6 or 8 feet from the water's edge. So I want to now talk about lipid cases with a point, because the lipids, as you heard earlier, there's some great drugs out. Dr. Glotty talked to you about some of the drugs that are coming along. I have 3 cases I just want to talk about how to lower lipids. The first is on a 78-year-old man, recent anterior STEMI. He's followed by a 3-vessel bypass, and he now is here to see you for cardiovascular follow-up. He's on atorvastatin 80 only, and he's on treatment for his type 2 diabetes and his hypertension. His diet could be better. Guess what? He eats a lot of ultra-processed foods. His A1C is 6.5. His blood pressure is okay. And his lipids you can see here. Total cholesterol 184, HDL 44, triglycerides a little high at 175, and then his LDL 105. So he's clearly above goal for what we need, especially after his recent event. So what should you suggest to him? Lifestyle, that's a no-brainer. It's always that. Ezetimibe, 10 milligrams daily. Evolocumab, 140 milligrams every 2 weeks. Icosapent 2 grams twice daily, or inclisiran. And here are his lipids. So if you look at the new guideline update that came out just a few months ago, it expanded on the 2018 update guideline. And it basically kept the same 3 questions that you ask every patient. Is ASCVD present? Do you have high cholesterol, LDL over 190 or the equivalent? And are you diabetic? And if the ASCVD is present, as obviously is in this patient, he's over 18, max tolerated statin, and now goals are back, thank goodness. 55 is the goal, recommended less than that. And ezetimibe is a class 1 indication to add to a statin before you give a PCSK9 inhibitor. And why is that true? Well, as you go on a statin or a PCSK9 inhibitor, as your LDL goes down, your cholesterol absorption, specifically through the cholesterol absorption site in your small intestine, is hyperactivated, and you absorb more, and that's what the ezetimibe blocks, is the Niemann-1, PIK1-like receptor in the small intestine. So that's why ezetimibe is indicated as a class 1 to add to this patient. We have new drugs, as was alluded to earlier. Ezetimibe, the one we just talked about, is indicated in homozygous familial hypercholesterolemia or hyperlipidemia that aren't a goal. It blocks the G1, the GI absorption, as we talked about. Icosapent ethyl, the new and improved fish oil that I was quite skeptical about when it came out. But the studies have really shown that it really is quite effective, and it's pure EPA and a special type of icosapent-ethyl. And it's indicated for triglycerides over 150 with a goal LDL. This patient is not a goal LDL. Patients have cardiovascular disease or diabetes and 2 risk factors, and it reduces triglycerides and clearly reduces events. Bempedoic acid is now available. You can give it for heterozygous FH or ASCVD, not a goal. The problem I have is it's an ATP citrate lyase inhibitor, and that's a couple of steps above an HMG CoA reductase inhibitor. And believe me, these patients can get side effects just like the statin patients can. The PCSK9 inhibitors block reduced PCSK9 levels with it's coming out of the hepatocyte. Then inclisiran is the new kid on the block, lowering PCSK9 levels through a small inhibitory RNA mechanism. And this may be a game changer just because of the way it's given every 6 months eventually, as we'll talk about in a moment. The only generic drug, though, on this list is ezetimibe. And when the ezetimibe did the outcome study that showed that it does clearly reduce cardiac events, it was called the Improve It study. The drug was $10 a pill. And everybody thought it was good, but we just didn't want to give it for $10 a pill. But what it showed was that lowering LDL from 70 to 50 by adding the ezetimibe to simvastatin in the study actually lowered cardiac event rates. And so if you would have come to me then when the study was being planned 10 years ago and say, do you think if we lower LDL from 70 to 50 we'll have a positive event rate inhibition? I'd say, no, I don't think so. But as we'll talk about in a moment, there's good reasons for that, and it clearly is beneficial. Icosapent-ethyl, it's an oral pill, $300 a month. Bempedoic acid, oral, $300 a month. The PCSK9 inhibitors are both injectables. The difference is that the inclisiran is injected at the provider's office or at an infusion center. And there are literally hundreds of infusion centers from California to Arizona to Texas to Florida for all the people that go south in the winter. We have one in Minnesota. But all these drugs, except for the ezetimibe, are expensive. They're all, as you can see, indicated by the FDA, added to statin and or diet or ezetimibe, drugs that usually give in front of them. So it's a stepwise approach is what we're finding now with lipid-lowering therapy, very similar to what you do with hypertension. Lifestyle, give a little bit of this drug, a little bit of that drug, lower doses. They work synergistically with different mechanisms, so you can really get good results. So I would say with this gentleman, give him ezetimibe. Now the NNT, or number needed to treat, for someone over 75 in the Improve It study was 11. So where else do we have something that says you can give a drug to 11 patients and one of them will have an event? That's pretty rare, even for interventional cardiology. That's quite rare. So that's why it's a class 1 indication. Now the evolocumab, he's not yet, if he doesn't get to goal with the ezetimibe, you can add it. Icosapent-ethyl would be once he's at goal with triglycerides over 150, and he's not at goal yet. Now why is the goal now less than 55? If you look at a regression study, this was intravascular ultrasound with one of the PCSK9 inhibitors, you can see that as we got down to an LDL of 90, about half the patients would have regression. But once you get to an LDL less than about 60, you start to get almost every lesion that can regress will regress. When I say can regress, I mean calcium will not regress. It will stay there the rest of your life. Scar will not regress. But lipid-rich plaque will regress. And so that's where you can benefit, and that's why this number of 55 has come to be so popular. The guidelines in the U.S. have finally caught up, partly at least, to the European guidelines that came out 3 years earlier. And part of that is there's always a delay with our guidelines in this country because our guidelines are very strictly defined on how they can be done. You need 2 randomized trials, et cetera. In Europe, you can have the professor say, this is good, but we don't do that in this country. So as you can see, here is the European guidelines goals in the middle. The shaded background is for secondary prevention. The clear white background is for primary prevention. And here's the level of evidence on the right. So what you see is on the left is the US guidelines now since last August. So this gentleman would be very high risk with ASCVD, LDL less than 55, and we agree on that. And you can see that the US and the Europeans in the middle here, certainly where it's class 1 evidence, we all agree. The top one, the Europeans say if you have a second vascular event on a statin, get an LDL less than 40. I've never seen a randomized trial like that, but I suspect they got that from the PCSK9 studies. Then the bottom one, we call low risk in this country primary prevention less than 100. And we'll talk about why that is. But the Europeans say less than 116. And why do they pick 116? Because that's an apolipoprotein B level of 90, which is where you want your ApoB level. So the guidelines now, if you have ASCVD, you're on the left, essentially your goal is less than 55. If you're on the far right, you have no high cholesterol greater than 190 LDL, no diabetes, then your LDL could be less than 100 unless you have other risk factors. Now, why do we pick 100? Well, if you look at the Get With the Guideline program, which Kim Eagle was the head of a few years ago, they said, what is the mean LDL at the time of first presentation to the hospital with urgent diagnosis? Urgent like acute coronary syndrome, STEMI, non-STEMI, unstable angina, whatever. The mean LDL, and you can, if you want to win a bet with the residents or the fellows, ask them what they think the mean LDL would be. If you say something about 150 or 140, they'll probably pick that one. They will never guess 105. In fact, I have, unfortunately, sometimes I've had to develop a way to talk to many of our patients in Rochester that come every year, and I'll say, your LDL's a little high. And they'll say, what do you mean? I come to Mayo Clinic every year, and I see, Dr. So-and-so, and they've never told me, 10 years, no one's ever told me my cholesterol is high. I'll say, well, I appreciate there's a discrepancy in how we communicate, and sometimes you hear different things from different providers, and I apologize for that. But I bet they tell you your LDL was normal. Say, yeah, my LDL is normal, so why are you telling me it's high? I said, we unfortunately confuse the term normal and average. And while your LDL may be average at 120 or whatever, it's not normal. And you want to be average for a risk factor for heart disease, the biggest killer in the world right now, and especially if you're an older man or older woman over age 50. So they say, oh, okay, well, maybe I should get this down a little bit. A second case, 51-year-old woman is seeing you for CV evaluation, family history positive for early MI and CABG. She's noted to have high lipids in the past, and her primary care provider said, why don't you try lifestyle changes? She's not on lipid-lowering therapy. And her lipids you can see here, total cholesterol 384, HDL is 55, triglycerides 110, LDL 307, and non-HDL 349. Her LPA, unfortunately, which is another triple whammy type molecule that deposits cholesterol like the LDL, it's also irritating and ruptures the plaque once it's deposited. And third, it has a clotting type molecule on it, so it clots the plaque. And if it's high, over about 125, is deemed increased risk. So here are her lipids. She's on nothing. What would you suggest for her? Continue her lifestyle, or add to it rosuvastatin 40 a day, or add that plus ezetimibe, or add the evolocumab. Do them all at once, or give them instead the first three in inclisiran. And practically speaking, you can really approach it from giving them rosuvastatin and ezetimibe, because a 307 is probably not going to get down to a goal less than 100 with just those two. And actually, her LDL should probably be even lower because she has this family history of early ASCVD, and she has a high LPA. So you'd want to get her well less than 70, if not less than 55. So she would be in the second group. The primary prevention is LDL over 190. Clearly it is. So she'd be a 55 or a 70 to try to get her to. And they have some risk modifiers or enhancers for the primary prevention. And the risk enhancers, I'll underline the ones she has, the family history. On the left, as Dr. Galati pointed out to you, we now have some very nice conditions specific to women, the preeclampsia, premature menopause. Inflammatory diseases is a big deal. And it's not just a psoriatic arthritis or rheumatoid, even degenerative joint disease increases your risk. So just garden variety, pain in your knee or pain in your hands will increase it. The ethnicity, the South Asian ancestry, at the same level of LDL, South Asians have a higher risk for a heart attack than non-South Asians. In patients with CKD, metabolic syndrome, they have chronic inflammation. So these things are really, to me, inflammatory issues. The more inflammation you have in your body, the more likely you are to have a heart attack. Why is it that when a patient gets a flu, that they get increased risk for heart attack? Because inflammation. Why is it that you get a flu shot? I tell my patients, please get a flu shot. And they say, oh, no, doctor, I never get the flu. I said, I don't care if you get the flu. I still want you to have a heart attack. And if you get a flu shot, you lower your risk of heart attack 50% during that flu season. So please get it. The other things, lipid biomarkers like LDL, obviously it's high, or triglycerides, because that's a pro-inflammatory state. Triglycerides make the LDL more oxidized. If you have a high CRP, again, that's the premier inflammation monitor that we check. Ankle brachial index that's low, LPA that's high, or you have an ApoB that's high. So all these things are things to at least think of in men, women, black, white, everybody that you see. And if you look at the PCSK9 therapies, which she's probably going to need, the three we have out right now are evolocumab, alirocumab, both sub-Q injectables every 2 to 4 weeks, or inclisiran, which is given at baseline 3 months, then every 6 months. And the difference, you can see there isn't much in how they reduce LDL, on the ApoB reduction, the cholesterol, the triglycerides. LPA reduction is it's the only drug we have right now that's approved by the FDA for LPA reduction, although it's really not approved for LPA reduction. We can use it for that. And you can see that that we have secondary prevention data out, a priori data on alirocumab and evolocumab. They have published some things from the Orion studies on the inclisiran early, but there's still the big phase 3 trial is ongoing. And everybody suspects it will reduce mortality, but you never know. Ever since the CETP inhibitors 10 years ago showed we raised HDL 50% and lowered LDL 50%, and they still had increased mortality. The FDA has said we want an outcome study on every drug that treats lipids. So the great thing to me about inclisiran, and we haven't used it much. It really it's so hard to get approved for patients right now, insurance-wise. But the great thing for me is the adherence. We have women that fly up from Florida to Rochester, Minnesota. In January, February, they get their flu shot, they get their osteoporosis shot, and they go back down to Florida. I asked the Mayo the other day to send me my data on the 450 patients I have on injectable every 2 weeks PCSK9 inhibitor, predominantly Repatha. And what they found was that 68% of my patients are adherent to 80%. And so that means they get 80% of their scripts filled. If I showed up for work 80% of the time, I think my boss would say I was not adherent. And then here is the same study, same slide. This is where she would be. And so I would say give her everything and write for evolocumab, and when it gets there in a few weeks, she'll be ready for it. The last study, very briefly, an 81-year-old man, non-STEMI, walks with a cane. He's statin intolerant, severe muscle pain on multiple statins. Now he's just on Repatha. And here are his lipids. Well, here are his lipids. Total cholesterol 164, triglycerides 108, LDL 87, clearly above goal. So he is one that's very high risk, a recent acute coronary syndrome, diabetic underlined, 65 years underlined. So he would be a high-risk patient. And what we would offer him, try once a week rosuvastatin. That's not approved by the FDA, never has been approved by the FDA, never has been prospectively studied by the FDA. Ezetimibe, icosapent bempedoic acid. Well, he's a high risk, very high risk. His LDL should be less than 55. So I would say try to give him once a week rosuvastatin. We have over 1,000 patients on it, and people that are intolerant to statins, as Dr. Galati was saying, it's not an argument you're going to win. When you tell them, oh, this is, the studies show it really isn't the statin, you're not going to win it. So we'll say get you on rosuvastatin 5 milligrams once a week. The recent guidelines actually encouraged less than daily statins, which was great to see for the first time, and then add ezetimibe. We've had some FH patients go from 220 down to 70 with just once a week Rosuva and ezetimibe. So it really is very helpful, but everything in life is a bell-shaped curve, as you know. Patient's response is a bell-shaped curve. So we try to give them things that won't bother them. These are the drugs, and this is the side effects. Every one of these has myalgias listed. And the newer ones, bempedoic acid and inclisiran, each have about a 5% myalgia rate, which is the highest rate we've seen in any of the, statins never had a 5% myalgia rate. So it's going to happen with these patients. The one thing I wouldn't give them is bempedoic acid because the side effect is tendon rupture. He walks with a cane because he tore his Achilles, had a rupture of the Achilles tendon. And then finally, this is kind of a summary slide of the drugs we now have. Across the top is what we're trying to treat. Across the left is the type of molecule we have. The ones I've underlined are the ones we use predominantly. Lowering LDL with statins and ezetimibe, and in adding evolocumab. I think we'll be maybe switching more to inclisiran as time goes on for adherence reasons. The triglycerides, the fish oil over the counter isn't bad, but if they have disease, I would really prefer to go to icosapent And then the LPA drugs are coming along. I have a patient now in pelacarsen for compassionate use, the first guy in the United States on it that's not in a randomized trial, because he has LDLs of 40 with high LPA and has recurrent events. And so we're giving it to him. The one that I think is very interesting, though, is olpasiran, and I like it. Why do I like it? I've never given it. It's still being studied. It's because it's a name that I actually understand. The FDA gave him an O to begin the drug name with, just like hurricanes. It starts with an A, then a B, then a C, then a D. They gave him O. Well, they start with O, then it's lipoprotein A, LPA, and it's a small inhibitory RNA molecule. So the name actually it's the only thing I've ever seen that makes sense. So to summarize, encourage healthy lifestyle. Diet is so important. If you don't have a healthy diet, you may as well not take the statin if you're a primary prevention. The data has shown that if you don't have a healthy diet, your numbers look better, but your mortality, your heart failure rate, your heart attack rate really doesn't change much if you have an unhealthy diet, even on the statin. If you have ASCVD, then basically the goal is less than 55. Remember, there are 3 goals now. Ezetimibe, very helpful, especially in these high-risk patients, diabetics, and elderly over 75. If the LDL is a goal and triglycerides over 125 to 150, think of icosapent ethyl. And then the PCSK9s are interesting, and we'll have to see where the bempedoic acid and inclisiran comes out. And then the anti-LPA drugs will be coming in the next 2 to 4 years. So I encourage everybody that treats these patients that has a medical electronic record, just put a file in there, a tickle file, that you can save a patient to a high LPA list. And then when the drug gets approved, just send them all a letter and say, hey, the drug's here. If you want to come in, we can talk about it. So thank you, and this was my friend that woke me up this morning about 6 o'clock right outside the door. I hope this talk was not a turkey, but thank you very much.
Definitely an excellent, very relevant talk to most of us. So what questions do we have?
Yes, do you have any recommendations for the highest EPA, any recommendations for over-the-counter, the highest EPA dose fish oil for the patients who can't afford the icosapent ethyl?
Yeah. It looks like about 6 grams a day of DHA and EPA, or if you can find EPA over the counter. I don't know if you can find that very easily. But you want to tell, we ask the patients to look at the bottle, and it all says 1,000 milligrams on the cover. You have to turn on the ingredients, and it's how much EPA and DHA actually are in the pill, which is different than the front. And so it's usually about 300 milligrams, unless you go to a box store and get the triple strength, which is 1,000. And so you take 2 pills 3 times a day, 6 grams a day. You don't really get much benefit beyond that. I don't, but look at the triple strength. Everybody, they're all generic, remember, so all the triple strengths seem to have them. All the box stores have them.
Yeah, I really worry about the triglycerides when it gets so high, worry about pancreatitis. What would be your recommendation? Somebody has close to 1,000, something that would really, be more effective.
Yeah. With 1,000, I look back at their record. Now with EHR, you can go back years. And if it used to be lower, that means it's probably somewhat lifestyle induced. So I would always get them to do 3 things. Take some over-the-counter fish oil, unless they're, qualify for icosapent. Start being active physically. Even 90 seconds 3 times a day has been shown to reduce your triglycerides of vigorous activity like intervals. And then the third thing is quit eating processed carbs. And believe me, we're all doing it. I had a Marine that came in once, and he quit the Marines. He rotated out of the Marine job, but kept eating like a Marine, but wasn't active like a Marine. And he would drink a couple things of juices, the Gatorade type juice. Wasn't very active. Triglycerides 1,200. I said, okay, let's get you down. He hadn't had pancreatitis. If you have pancreatitis, you put him on some fibrates or something, or if it's a genetic thing. But he started changing his lifestyle. 6 weeks, he was down to 400, and then about 2 months later was down to about 200. So it can be done. But you're right. If they've had pancreatitis, they're going to be very compliant with the meds.
Okay, thank you.
It's not pleasant. Yes. Yes, sir.
So frequently, after a patient has an MI, they get placed on 80 milligrams of atorvastatin in the hospital. Mm-hmm. Is there a reason why we don't use more rovastatin 40 milligrams, or what's the rationale?
Yeah, well, the rest question is, why do we use atorvastatin 80? Because that was the trial that was done. They gave people atorva acutely at the time of a heart attack. You can put them on 40 of Rasuva, that's fine. We tend to have them come back in a month, and we reassess them and see how they're doing, and then we make a decision about how are they tolerating it and long-term therapy. But that's a good question. We just have the data. Yes, sir.
That was a great talk. Thank you so much. I guess one question that comes up is, should we be more routinely checking APO, LPA, these lipid panels that aren't traditionally in just the standard?
Yeah. Lipoprotein A, it's recommended by the guidelines to check it on anyone with a first-degree relative with an early ASCVD, meaning less than 65 for a man, less than 55 for a woman, that you ought to check it. And what you're going to see in the next 3 years is a new disease, and it's called LPA disease on the TVs. Remember, PAD came along a few years ago because they had treatment for it, and now they're going to have treatment for the lipoprotein A. So it'll start to be having patients come in and say, doctor, can you check my LPA? I need to be treated for it, which I don't think is a bad thing. And I also encourage anybody that treats these patients to have a form letter made out that I give to the patient or send it to them in the portal. And it says, dear patient, you have high lipoprotein A, your increased risk is genetically determined. Give your first-degree relatives this letter, and they can take it to their provider, and this is what they should have checked, lipid panel and LPA. And, because not everybody has a happy Thanksgiving talking to their relatives about their cholesterol. And, you can talk to a man, and he'll never talk to his siblings. I had a woman the other day, and I said, what about your daughters? By the time I went out to the desk and came back, she had texted all of her sisters, rather, and she had the answer from every sister, about their LPA. So, but you need to give it to them and make them aware, and it's their decision, but I encourage them to follow up on it.
So,
okay.
One follow-up was just is 50% reduction no longer adequate?
Yeah, 50% reduction was what the studies were based on. They tried to get a 50% reduction from the statin, dose. And they've gone away from that. They've gone more to an absolute LDL for that reason I showed you, that the LDL of less than 55 is the one, or less than 60 is where you start to get regression. So I think that's very helpful, because you can get, if you look in the Crestor package insert in the PDR, they have a great slide in there, a graph that I've never seen published, but they did all this data, AstraZeneca did, of 4 drugs compared to Crestor at different doses, and showed how some people get a better reduction with 20 of simvastatin than they do 40 of rosuvastatin. So it's very independent. It's very genetically driven. We just don't have a genetic test to tell us which one to give them. But so the guidelines do encourage, the new guidelines in 2022, try different statins to see how the patient responds. So it's not just tolerance, but also efficacy.
LDL is becoming the most important of all the lipid panel from your talk. I remember those small, dense LDL, different type of LDL.
Yeah.
Number one. Number two, once we have a baseline lipid panel, and since LDL is the most important, can we just follow the LDL alone, because HDL doesn't change much, and I don't even know how to improve the HDL most of the time.
Yeah. Well, the LDL is, it's the one we've always studied. It's been the most studied. It's calculated. It's not measured. And that's the reason we have to get the panel, because they calculate the LDL from that. And I do think that's, you can draw an LDL to actually measure it, but that's more expensive than getting the panel. And then when the triglycerides are over about 200, it's suggested that you try to do an apolipoprotein B, because the formula kind of falls apart. It doesn't matter if you're using the new NIH one, which is probably the best. The Hopkins-Martin equation is the one that people have been using. The NIH equation is actually better for calculating LDL. So I would say try to measure it if you really have high triglycerides and you're concerned. But otherwise, I think it's just the calculated's fine. Dr. Khan, you had a question?
You want to make a comment on homocysteine?
Make a comment on homocysteine. So homocysteine is a risk factor, and it's been shown that if you take folic acid, it actually lowers it, and it lowers vascular events in the venous system. But it doesn't lower vascular events in the arterial system that I've seen. If you know of different data, let me know. But homocysteine is a risk factor. But to be honest, there's about 250 risk factors that have been bona fide published. And so I just tell patients to focus on the one risk factor that's right here, their mouth. That's the one that's by far and away the one that's been forgotten. Anything else?
In any of the statin studies, has there been any correlation with reducing atherosclerosis in the brain and reduction in any kind of neurological problems?
Well, there have been. I haven't seen any studies showing actual plaque regression. They may have had some, but I have not seen them. We've seen that in the cardiac world, that you had plaque regression. But clearly, if they have elevated LDL, even the neurologist is starting to give patients statins. And it's indicated for people that have ASCVD that's not embolic, and they have carotid plaque or plaque in their coronary arteries. The brain's an interesting organ. The cholesterol doesn't get across the blood-brain barrier. Statins do. The brain makes its own cholesterol, and like many of our tissues, but the brain makes it. But you have to be careful, because people have read on Dr. Google, and now it's going to be Dr. Chat GPT, that you can actually have brain fog from statins, and so you'll have to deal with that. But it's indicated.
So the follow-up on that, how about involving dementia specifically?
Dementia, there's not been a good study of prospective, as you can imagine, for dementia with statins versus not. If you look at databases, people that have been on statins have less dementia. Is that because we don't give demented patients statins? It's not clear, but it does seem to help microvascular ischemic events, which seems to lead to some forms of dementia. So I think that it's all these arteries are connected, and I try to treat them for everything. And if they can tolerate it. And the key to the recent guidelines is that a little something is better than nothing, and the earlier you give it in their life, the better it is for them in the long run. So we're trained ever since one of my personal heroes growing up in Texas, Lyndon Baines Johnson, passed the Medicare Act in 1965 that said we are going to wait until you're 65 and treat you with a ton of things and spend a ton of money on you. You know what the average lifespan in the United States was in 1965? 67. So now the average lifespan is 2 decades longer, and we need to change our paradigm and say, let's not wait for this disease to occur. And we do not have, any AI that yet changes how our patients do their lifestyle. The one thing I've seen at Mayo, we have AI on ECGs that tell you your heart age by ECG and your chronologic age, you know. And if my heart age is 17 years younger than my ECG age, or than my chronologic age, and I tell that to patients, and they start to say, what does this mean? Am I going to die earlier? Am I going to have a heart attack earlier? I say, yeah, all the above. We don't really know what it means, but I do know your heart is older. And just like your face, you don't want your face to look 17 years younger than your chronologic age, do you? So we need to start showing. Okay.